And finally, we will also be joined by Dr. Liao. She will be participating only during this, speakers discussion sessions. She brought her own questions to engage with some of the speakers. So I will briefly introduce Dr. Liao. She is currently the Vice Chairman of the Cancer and Gynecological Disease Prevention and Control Committee of Guangdong Provincial Association of Ethnic Medicine in mainland China, and an expert in the Technical Committee of the National Maternal and Infant Health Engineering Technology Research Center, and a member of the European Society of Human Reproduction and Embryology. Welcome, Dr. Liao.
Thank you all for your very good presentations. So we don't have much time, so my first question goes to Professor Miyuki. We can see that the subsidy to the health insurance changed in Japan this year from April makes more people seek IVF treatment in your clinic, especially those who got the first OPU try. This is, I think this is a really progress in IVF insurance in your country. My question is, what the clinical practice rate is in your clinic now? And is it increasing or declining? And what factors do you think affect the outcome?
Thank you for your question. Unfortunately, we don't have yet the statistics because we just start the insurance system as of April, so that some people, of course, go through already through to the ED cycle, but some people not, because as I show you that most of the cycles in Japan are frozen cycle. So, but in my impression, the clinical pregnancy rate is a little bit higher than the last year. And I expect that it is because of the 1 year younger age of women's receiving ART. As I show you that average age of women receiving ART in our clinic, it is almost average in Japan is around 38 or 39. So that I think that 1 year at the age group is very important to decide the prognosis of the IVF cycle. Thank you.
So because of the change, you helped a lot of very easy, that is good prognosis patients.
Yes, must be, yeah.
Yeah, so it's good. And my second question is, if the insurance for endometrial test like EAR, MO, ALICE is private only in the UK, so the indication for those kinds of tests is becoming even more important for us, for the doctors, because the patients have to pay by themselves. So what is the correct information we should give to our patients according to your opinion, Dr. Professor Thornhill? Can you help me?
Yeah, of course. Well, I mean, the way that we've developed the test and is to say the evidence that we have says that it's good for recurrent implantation failure. And so when we speak to doctors, we're getting kind of a mixed response in terms of they say, yes, I think it will be useful, but how many failures do I need before I start applying it? And the truth is, everybody wants to be evidence-based, but in a private setting particularly, which is the only setting in the UK where you can really provide endometrial testing, as we've discussed, doctors want to find something to do next that's different. they don't want to just do the same thing over and over again. So particularly if you've used PGTA, in some centers they're using PGTA, so they've spent a lot of effort and money. I'm not saying that they've done the right thing or the wrong thing, but they've done all this with the patient, and now they're saying, what if the endometrium isn't appropriate? So it's that extra incentive to kind of do something additional. The actual RCT evidence we have isn't from recurrent implantation failure, it's from first-time IVF. So we've got a huge amount of, you know, retrospective and other forms of study saying it's good for recurrent implantation failure, and actually the RCT evidence we have is for first cycle IVF. So it's a difficult picture, but what I'm really interested in is why, you know, so if I sort of up level the question, is why some of these additional tests, how they become advanced medical care, like we heard from Japan, and what method is used to determine whether they get into that category or not. And then the second part to that is, why can they not be part of a funded cycle? You know, so if all, it seems to me there's an implicit bias against using any additional test, because it almost seems like if the state has paid for a cycle, there's going to be some compromise by using an add-on, you know, versus no benefit. It's like, it must be harmful. So I'm confused about what the rationale is behind not mixing and matching between a state-funded cycle and a private add-on. I don't know if that answered your question, but you know, I think it's complicated. You know, we have clear indications for using the ERA test, and it's usually 2 or more implantation failures with good quality embryos.
Yeah, we do. Thank you.
Thank you, Dr. Liao. Is this your last question? Would you like to ask anything else?
This is my last question. Thank you.
All right. So yeah, this space is also for all of the speakers. If you want to ask each other questions, feel free to use the time we have right now. I know that Professor Thornhill has a few points he wanted to touch during this discussion time, so you can also ask the other speakers.
Can I ask a question? Can you hear me?
Yes.
Just like I ask a question to Harada Sensei. I'm just thinking about, with the change in the, you know, now Japan has allow the funding, public funding for IVF treatment. Would it change? I mean, I've gone through the transition, but do you think it would change practices, IVF practices that are traditionally done in Japan? For example, you know, there was a lot of natural cycle, there was a lot of minimal stimulation, and then I'm thinking that, you know, once the government decides that, okay, it will fund this sort of you know, IVF, people will change or are forced to change and not do what they were doing before, so that they can comply with what is being funded.
Thank you for your question. First, as I show you in the slide, most of the drugs or medication approved in the healthcare national health insurance system. So basically, we don't have to change the cost protocol or anything, but now the indication or dose of drug or medication is strictly limited by the health insurance system. For example, as you know, we are using many mild stimulation protocol with CC for 10 chlorpheniramine citrate for 10 days or more, but the health insurance system just allow us to CC for 5 days. So we have to switch to CC plus HMG or sometimes antagonists. So we are forced to change some cost protocol. So we don't expect what changes may occur in the pregnancy rate or success rate in ART. We have to wait to watch and what happened in our practice. And regarding the add-ons, like ERA test or time lapse, it is only admitted as advanced medical care. So we can do medical care covered by national health insurance and advanced medical care at the same time. So most of the add-ons are permitted as advanced medical care. So we are not so confused about it, but only PGTA is not allowed as advanced medical care and just acknowledged as private practice. So now we are very confusing and about that problem, and we are now trying to apply government body to admit as a advanced medical care, but still not successful yet. Yeah. Thank you.
Thank you.
Thank
Professor
you,
Thornhill, can I ask a question? I know you, and this will always be the same, like there is no right or wrong answer, but you have to draw a line somewhere in terms of if you were a government, whether it be Singapore, Malaysia, Australia, UK, Japan, there must be a line that you need to draw, and then where you draw that line is up for debate. But something like ERA testing, for example, or PGTA, and things have progressed. Like in Singapore and Australia, same thing. PGTM and PGTSR has now gone on to the rebate system, and then maybe later on PGTA might be. But it's always very hard to decide. What is going to benefit. Because it is a publicly funded thing. So have you got any comments of how you can draw that line? I don't know whether RCTs is the way to go or not, but have you got any comments about that?
Well, one of the issues I have with the UK regulator is that they've decided it's RCTs or nothing, and I think that's the wrong approach for IVF. I think there's some more nuances needed. But one of the issues I have is, and we've had it clarified from Japan, that, okay, let's say PGTA, and again, I'm not saying, it definitely works, you should definitely use it. I'm just saying it just seems a bit odd that you can't do a funded cycle and add something into it, out of your own pocket, unless the implicit idea is it must be harming, it must be wasting the public's money. So that I have a little bit of a problem with that. I just think that's a strange way of doing it. I agree that you have to draw lines. I mean, lines are there to even say, we'll give you 3 cycles of IVF, or we'll spend this much money, because at some point you just haven't got an unlimited pot of money. So I understand that. I just don't think the boundaries for where something becomes acceptable or not are very clear. And there seems to be, and PGTA particularly, it has got a long and controversial history. So I understand that that's a little bit of a problem child. But I showed the traffic light system that we have in the UK. We're all talking about endometrial testing like it's quite accepted. And again, I'm not promoting it. I'm just saying it seems quite accepted. In reality, in the UK, that's now got a red traffic light as well. So it's being classed almost exactly the same as PGTA. But I know lots of clinicians who are kind of bending the rules in the UK, saying, while it's got a red traffic light and it's not NICE recommended, I'm still going to allow patients to pay for it in an IVF cycle. And I'm thinking, this is just too grey. This is not clear enough. I mean, I like the greyness because it means clinicians have a little bit more autonomy. But it just doesn't seem fair to patients. It doesn't seem clear and standardized for patients. And I think that's a problem. And all of the talks, I mean, they're great talks, and it's fascinating what's going on in other countries. And I like the kind of the detail and complexity in Japan. But when it all comes down to, if you're a patient in a vulnerable state, aside from how much money you might end up paying, it's just really confusing about, where you would go, what pots of money you need. It just looks very, very confusing and complex. And I don't know if there's a way to make it simpler. I mean, I suppose this segues nicely into a question I have for Professor Harada, and that is, do you think it's fair to have a standard tariff for IVF procedures regardless of the eggs and embryos? So you were telling us about in Japan, you know, the fee is related to the number of eggs and embryos, if I understood it correctly. Whereas in the UK, and I'm not saying this is better, it's independent of the number. It's sort of like, well, this is your fee for collecting eggs. But I do understand there's a lot more work and a lot more cost associated with, you know, 30 eggs versus 2 eggs. But is it fair?
Yes, I agree with you that the same, I mean, the same payment, the same money for independent of their egg numbers is more fair to patients. I agree with you, but I think that I don't know precisely that why that this our health insurance system takes this system. Takes this system. I mean that it different between the depending on the numbers. But I think it is maybe that in line with our previous practice and under the private practice, many hospitals set a price according to the numbers of eggs or oocytes, because as you told me that because of the depending on the work or and many yes, such a thing. So I think the health insurance system just follow that kind of practice as we usually do. But I think, yeah, I agree with you that it must be discussed in future. Thank you.
Thank you all. Thank you, Dr. Harada, for the very clarifying explanation. Unfortunately, we do not have a lot of time, so I will jump now quickly to the audience questions. And actually, our team we have a lot of questions and good engagement from the audience, so they're very interested in the points that you raised here. But I'm going to read the question selected by our team. So they selected a question that was, it's for, again, Dr. Harada. I will read it for you. So out of all add-on treatment items, why is PGTA the exception outside advanced medical care system in Japan? And is it due to the lack of evidence available or due to other reasons?
Actually, I don't know that complex reason, but let me explain that how to decide whether this add-on go to health insurance coverage or another one is advanced medical care or not. And the government sets that the system according to our guideline published in last year by Japan Society of Reproductive Medicine, and in the content, various techniques are categorized as always that recommendation A, B, and C. And technique with it is based on the publication search, and in the technique with recommendation A and B, it almost go to that health insurance coverage. But technique with recommendation C, it almost goes into the not covered. And among them, actually, that PZTA is set as with recommendation B, but as you may know, that so basically it must goes to covered by health insurance. But as you may know, that genetic testing like PZTA evokes much discussion among in the society, and so of course some people agree with that, but some people very offensive about that topic. So maybe that's the conflict of that, the disagreement in the society lead to this technique not covered by health insurance. And also with other add-ons like time-lapse and error and two-step and seat, we can very easily apply to the government body and admit them as advanced medical care, but it is not such simple in PGTS setting. That is my speculation. Thank you.
Yes, thank you. Yeah, PGTA is no easy topic to navigate in Japan for sure. It's very delicate, has a lot of ethical capillaries that you can find there. Okay, so unfortunately, we will not have the time to ask all of the questions. So in these last minutes of the session that we have together, do you have any final questions or remarks that you want to make to the speakers want to make to their peers or to the audience?
I just want to say one thing about PGTA in Singapore. So even if you wanted to do, and even if you're happy to pay for PGTA in Singapore, the government does not allow you to do PGTA in Singapore. You have to apply. It's very, very hard to get permission to do it. And the main reason is due to sex selection. So they want to prevent completely sex selection. We have, the same problem in Australia. Australia has no laws against sex selection, but it is not practiced in Australia. So PGTA, maybe not in Japan, but in Singapore and around this Asia Pac area, areas where there are lots of Chinese and Indians, sex selection is quite a growing problem. And Singapore has decided that it doesn't want that practice done, even if you decide you want to pay for it. Rightly or wrongly, again, I'm not saying whether it's right or wrong, but that is the reason. So we have, in Australia, we have tried to say, you can still do PGTA without revealing the sex of the child, and we've done it very successfully in Australia, even without laws.
Okay. Few other features of PGTA in Singapore and Australia. Professor Thornhill has raised his hand.
I was actually, Dr. Khan said almost exactly what's happening in Australia with PGTA is the same as the UK. I was going to endorse that and say it's another dimension, another nuance to PGTA, that it could be used for sexing rather than antibody screening. But in the UK, even though it's not endorsed by the HVA or funded, it's allowed. It's not against the law, but the sexing is against the law. So exactly as you've described in Australia, it's the sex results, unless it's medically important, like XXY or Turner syndrome, are not revealed. And that system works, and everybody understands it. So it hasn't been a problem for that reason for us.
Okay, thank you. Thanks, Alan, for your remark. And we are now approaching the end of our event. So first of all, I want to thank all three speakers for joining us. It has been a pleasure to hear what you had to say and to watch your presentation, so detailed and so interesting about the many different, levels and cracks of each system. So it really gave us a view of the bigger picture here for each one of those regions. So thank you very much for all the work and effort you have put on your slide decks and on the information that you brought us today. And thank you for our audience, everyone who stuck with us so far. We want to thank you for listening, and thank you for all the questions. We can continue these discussions by email, as we will make available the QR code, our contact. So if you want to engage about this topic after this event, you can do so by scanning the QR code, which will appear in the screen.